The subcommittee will come to order. The chair recognizes himself for 5 minutes for an opening statement. Dual eligibles, those individuals who are eligible for both the Medicare and the Medicaid programs, are one of our sickest, poorest, most costly, and most vulnerable populations. If we are to simultaneously improve and lower the cost of their care, we must do a better job at integrating Medicare and Medicaid benefits and services. Dual eligibles are unique. While more than half of dual eligibles live below the poverty line, only 8% of Medicare-only beneficiaries have incomes below the poverty line. 19% of dual eligibles live in an institutional setting, while only 3% of Medicare-eligible only individuals live in such a setting. They are also more likely to be hospitalized, to go to emergency rooms, and to require long-term care than other Medicare beneficiaries. According to the Centers for Medicare and Medicaid Services, more than 9 million people fall into the dual eligible category. 43% of them have at least one mental or cognitive impairment, while 60% have multiple chronic conditions. According to the Kaiser Family Foundation, dual eligibles who make up only 15% of Medicaid enrollment consume 39% of total Medicaid funding. Additionally, in 2005, the Medicare and Medicaid program spent an average of $20,000 per dual eligible, almost 5 times greater than the average amount spent on other Medicare beneficiaries. These individuals who have fewer resources and more complicated health care needs face the added struggle of trying to navigate both Medicare and Medicaid. Medicare covers their basic acute health care services and prescription drugs, and Medicaid fills in the gaps. Medicaid generally pays the Medicare Part B premium and the cost sharing for Medicare services. For some, Medicaid also covers various benefits not covered by Medicare, including long-term care supports and services, dental care, eyeglasses, and other benefits. Each state determines its own eligibility standards and which benefits will be provided to Medicaid beneficiaries. So we're able to watch various states experiment with different models and designs to better align the care of dual eligibles. Currently, 15 states have been selected to receive funding, data, and technical assistance from CMS to develop a more coordinated model of care for dual eligibles. We can improve the quality of care that dual eligibles receive. We can make their care more efficient and easier for them to navigate. We can do all this while lowering costs to both the federal government and the beneficiary. I look forward to hearing from our witnesses today about which models are being tried in the states and what we have learned so far. This time I'll yield 1 minute, the remaining time to Vice Chairman Dr. Burgess.
Thank you, Mr. Chairman. In no other area is the lack of coordination at the federal level more apparent than when we deal with people who are dually eligible for Medicare and Medicaid. The population and studies of the population make it clear that Medicaid is actually 56 separate programs administered by the states and territories in the context of duals. It sometimes becomes a game of hot potato. Data suggests that duals are sicker when they're hospitalized, that their costs are almost 10% greater, and they have more episodes of avoidable hospitalization. It's a symptom of no one being held accountable for their care. Certainly better alignment of Medicare and Medicaid is needed. Now, unfortunately, ACOs, accountable care organizations, that may have provided a model and a good place to start, it seems that once again the bureaucracy has killed any such hope for that happening. The rule that was produced on ACOs was virtually unintelligible, and most large groups that thought themselves to be ACOs have now moved away from this. You want to drive cost savings with better care? This is a problem that really we could solve. 15% of Medicaid enrollees are duals, and they account for almost 40% of the program spending. The old Willie Sutton law, you rob banks because that's where the money is. Clearly it should apply here. And these patients are fully covered by Medicare and the entire Medicare benefits package, and still they're 5 times costlier. These are patients that are defined. We know where they are. We know who they are. We know when they're accessing care and why they're accessing it, and yet, for some reason, we lack the fundamental amount of consistency for coordinating their benefits. I rarely find myself agreeing with Ezra Klein in the Washington Post, but I did last week when he talked about the fact that this was an idea whose time has come. What I don't understand is why it takes an entirely new federal agency when CMS has had broad waiver authority and demonstration authority for years to take care of this problem. I'll yield back the balance of my time.
Chair, thanks, gentlemen. And you recognize the ranking member of the subcommittee, Mr. Sloan, for 5 minutes.
Thank you, Mr. Chairman. I really welcome today's hearing on a critical issue, the coordinating and improving of health care of those dually eligible for Medicare and Medicaid programs, otherwise known as dual eligibles. And I appreciate my colleagues for working with us in preparing this hearing and look forward to our discussion. This is an area of our healthcare system that I think has potential for effective change. The reality is that dual eligibles are a vulnerable population. Their care is both costly and frequently uncoordinated, which is resulting in poor outcomes in many cases. In total, there are 9.2 million Americans who rely on both Medicare and Medicaid. Meanwhile, they are significantly poorer and tend to have extensive health care needs. Overall, they're more likely to suffer from chronic conditions such as heart disease, pulmonary disease, diabetes, and Alzheimer's disease. And as such, their care is complicated, and too often they're not receiving the patient-centered care they need and that they deserve. In addition, dual eligibles represent less than 20% of the Medicare and Medicaid programs, but bear the responsibility for a significant amount of the program's expenses. In fact, in 2007, they comprised only 15% of enrollees, but represented 39% of Medicaid spending, and their medical costs were more than 6 times higher than non-disabled adults in Medicaid. Meanwhile, in Medicare, they represent 16% of enrollees and 27% of expenditures. Compared to all other Medicare enrollees, the health costs are nearly 5 times as great. Now, these are powerful numbers that demonstrate if we can improve care coordination and make life better for these individuals, there's also an opportunity for savings. That's why in passing the Affordable Care Act, we created the Federal Coordinated Health Care Office at the Department of Health and Human Services, otherwise known as the Medicare-Medicaid Coordination Office. Its mission is to gain some much-needed efficiency within the system for this group of beneficiaries. I must admit the timing of the Coordinated Office, as well as today's hearing, couldn't be better. Congress and this committee are increasingly concerned about the rising cost of Medicare health care coverage for the 45 million elderly and disabled Americans and Medicaid's 55 million poor patients. So what better place to explore, understand, and address than the sickest and most expensive populations to cover? But we mustn't set a price tag on their care, nor should we shape policy with the goal only of saving money. It's clear that we have some real big challenges, yet some very big opportunities in providing care for dual eligibles, so I look forward to hearing from our expert panel today. And I'd specifically like to welcome Ms. Melanie Bella, the head of the new coordinated office. I know that she has a long history of aiming to restructure the services of dual eligibles, so I look forward to hearing about her innovative work. I also look forward to hearing about the successful efforts represented here today by the different panelists. I hope we can hear some new ways Congress can be helpful in addressing what's been a long-standing problem facing our healthcare system. And I yield back, Mr. Chairman. Thank you.
Chair thanks, gentlemen, and recognizes the full committee chairman, Mr. Upton, for 5 minutes.
Well, thank you, Mr. Chairman. According to CMS, more than 9 million Americans qualify for both Medicare and Medicaid, including at least 257,000 in Michigan. I want to thank our 2 panels this afternoon for agreeing to share their expertise in serving this vulnerable population, often referred to as dual eligibles. We look forward to hearing your perspective on the health care needs and barriers that currently prevent them from properly navigating the health care system. This hearing is important for 2 key reasons. First, we must understand the distinctive behavioral and physical health care complexities associated with dual eligible populations. And second, we need to better understand what is currently being done to help these individuals navigate the healthcare system. And by the end of the hearing, we ought to be able to identify what initiatives exist to effectively integrate care for dual-eligible populations, what coordination models are working, what prevents these effective models from expanding, and building on the positive efforts already underway, we must also look for ways to modernize the current structure so that these individuals are ensured access to quality health care with less red tape. Most Americans have uniform coverage that guides them through the complex healthcare system. But for the dual eligible, that process is more complicated because they have to navigate the waters of two different entitlement programs that offer different benefits and cover different services and providers. And because of that segmented structure, we have to come to learn that dual eligibles have difficulty identifying where to access good quality care. Not surprisingly, they frequently end up in the ER, which is harmful to both patient and taxpayers who end up with a costly bill for preventable hospitalizations. Again, we welcome you, and I yield the balance of my time to Dr. Cassidy.
Thank you, Chairman Pitts. Medicare and Medicaid are important programs that are unfortunately unsustainable in their current form. Medicare, per the actuaries who run the program, is going bankrupt in 10 years, hastened by $500 billion extracted from it by Obamacare. Medicaid is bankrupting states, and this is before the Obamacare mandates that usurp state rights. Now, as a doctor who still teaches and treats the uninsured in a public hospital, though, my primary concern is patient welfare. And fortunately, there's an opportunity for improvement. As we know, dual eligibles oftentimes have poor outcomes. Now, Republicans have proposed freeing states from the rigid Medicaid rules, which make it difficult to coordinate benefits between Medicaid and Medicare. We've also put forward a plan to save Medicare from bankruptcy, to preserve Medicare as it has been known for those who are on it, and to preserve it for those who will be on it. Now, saving Medicare from bankruptcy is important for all Americans, all senior citizens, but particularly for dual eligibles. Now, unfortunately, under the current situation, Medicare provides incentives to treat patients in one way, and it provides Medicaid incentives to treat patients in another way. And these dueling incentives oftentimes lead to poor patient outcomes. This is the problem of large bureaucracies trying to dictate what happens to a patient in a patient's exam room. We can do better. So despite the fact that Medicare and Medicaid spend disproportionate amounts upon dual-eligible patients, again, our outcomes are poor. And this is actually the most important issues. Now, we should note that we shouldn't take the policy of do nothing for short-term political gain and kick this issue or Medicare's fiscal solvencies as an issue down the road. We've got to address it now. I'm very interested in the perspectives presented here today. I've had the pleasure to speak with Ms. Bella. She's knowledgeable. I just look forward to it. Similarly, the perspective of the PACE providers in the states. I will say of the Office of Dual Eligibles, I kind of like that. It's the one provision of Obamacare I applaud. As we say in the South, even a blind hog finds an acorn every now and then. I yield back.
Chair, thanks, gentlemen. Recognizes the ranking member of the full committee, Mr. Waxman, for 5 minutes for opening statement.
Thank you very much, Mr. Chairman. As observers of this hearing will note that by and large, whether you're a Democrat or Republican, we care about this issue, and this is a hearing where we have collaborated in providing panels that will give us the best information on how we can address the problems that are unique to the people who are dual eligibles or both on Medicare and Medicaid. This has been a major issue facing both programs. By design, these individuals should have access to the best of these programs, the best that each one has to offer. But too often they struggle, fall between the cracks, and cycle in and out of nursing homes, hospitals, specialty care, without receiving the coordinated, patient-focused care they deserve. Dual eligibles are not a homogeneous group, but they can be considered as several subgroups. Some, such as Medicare beneficiaries, who are eligible for Medicare by virtue of the age, and for Medicaid because they have low income, can be in their mid-60s and may not differ significantly from other Medicare beneficiaries in their need for care. Others, however, such as adults under 65 with developmental disabilities, such as cerebral palsy or intellectual disabilities, require significantly more care and resources to live their lives. Older Medicare beneficiaries with cognitive impairment, such as Alzheimer's, are another significant and very frail subgroup, a group we're going to hear about today. Many of these individuals may require nursing home level of care or home-based support services, allowing them to live outside of an institution. A disabled person under the age of 65 costs Medicare and Medicaid between $23,000 and $84,000 in 2005, depending on whether he or she needed a nursing home stay. This is very expensive, but not getting this care is worse, resulting in eroding health, trips to the emergency room, suffering for the patient and his or her family, astronomical costs for the patient and the taxpayer. These costs present both a challenge and an opportunity to develop and implement reforms that over time will simultaneously improve care while reducing costs. There is a Medicare Payment Advisory Commission, and the Medicaid and the Child Health Program have their commissions as well. And all these commissions have described how a lack of coordination between Medicare and Medicaid can create harmful and wasteful outcomes and misaligned incentives. For example, a nursing facility may find it profitable to transfer a complex patient to a hospital, even if the facility is capable of managing that patient, because of different payment rates and benefit rules in each program. We've heard in this committee many times over the years about problems generated by pure fee-for-service medicine that provides no coordination of benefits. For dually eligible beneficiaries, those problems are multiplied because of their intensive care needs. We face a lot of challenges in improving care for dual eligibles and reducing costs to the taxpayer, but it's important to recognize that we shouldn't rush into new programs for purely a budgetary focus. We should not assign a price tag to this population and then design the policy around it. As we'll hear today, the best and most successful efforts to integrate care for the duals has been local, and it's been focused on a small group of beneficiaries. These programs have been built around intensive interventions by nurses, physicians, social workers, therapists, and others. But these interventions can be difficult to scale up to a large population, and I think we need to be wary about grand promises regarding this decades-old problem. I want to mention that one of the results of the Affordable Care Act, which some people call Obamacare, was to extend the Medicare Trust Fund. And in fact, it was extended over 12 years. Another thing to recognize is that whatever cuts some of our colleagues objected to in the Affordable Care Act, they took all of those cuts and went way beyond it in their Medicare proposal, which they would transform into a whole different system. We have opportunities to save money. We are spending on dual eligibles by examining the drug rebates in Part D, where we pay a higher price for the dual eligibles than we used to pay in the past. Providing better coordinated care, saving money are not mutually exclusive goals, and for the dual eligibles, this may be the key to improved quality of care. Thank you, Mr. Chairman, for calling this hearing.
Chair, thanks, gentlemen. We have two panels today, and I'd like to ask panel one to take her seat at the witness table. I want to thank all the witnesses for agreeing to appear before the committee. On panel one, we welcome Melanie Bella, who is the director of the Medicare-Medicaid Coordination Office at the Centers for Medicare and Medicaid Services. Your written testimony will be made part of the record. We'd ask that you'd please summarize your opening statement to 5 minutes, and then we'll go to questions and answers. Welcome.
Yes. Good afternoon, Chairman Pitts, Ranking Member Pallone, Chairman Upton, Ranking Member Waxman, and members of the subcommittee. Thank you for the invitation to participate in this discussion today. My name is Melanie Bella, and I'm the Director of the Federal Coordinated Healthcare Office at the Centers for Medicare and Medicaid Services. This office, which we are referring to as the Medicare Medicaid Coordination Office, to better explain our mission, was created by the Affordable Care Act, and our single focus is the topic of the hearing today. Medicare and Medicaid enrollees, also referred to as dual eligibles, are a heterogeneous group. They include low-income seniors, individuals with disabilities, as well as those with serious and persistent mental illness. Some individuals start on Medicaid and age into Medicare. Other individuals start on Medicare and have a functional or financial decline that makes them Medicaid eligible. Either way, these individuals have very complex care needs. 3 out of 5 have multiple chronic conditions, and 2 out of 5 have at least one mental or cognitive impairment. Not surprisingly, given their higher than average health care needs, the cost of providing care for these individuals is significant. Together, Medicare and Medicaid spend roughly $300 billion a year to provide care to this population. Our office is working across Medicare and Medicaid with states, providers, and other stakeholders on a number of key initiatives to ensure better health, better care, and lower costs through improvement for Medicare and Medicaid enrollees. Specifically, our efforts are focused in 3 main areas. The first is program alignment, the second is data and analytics, and the third is models and demonstrations. I'll highlight a few of those efforts today, starting with program alignment. Better coordination begins with program alignment. Currently, Medicare and Medicaid enrollees must navigate 2 completely separate systems: Medicare for coverage of basic acute care services and drugs, and Medicaid for coverage of supplemental benefits such as long-term care supports and services. Medicaid also provides help with Medicare premiums and cost sharing. Although both programs provide important benefits, they operate as separate systems with different administrative procedures, statutory provisions, and payment policies. One of the first objectives of our office was to catalog all of the places where Medicaid and Medicare literally bump up against each other. This creates barriers to effective care. And through internal and external consultation and outreach, we use that opportunity to identify places where we could improve alignment between the 2 programs. We have published a list of these alignment opportunities in the Federal Register specifically to invite public comment. This alignment initiative will allow us both to identify barriers to high-quality, cost-effective care, as well as prioritize areas for improvement. Another key objective of this new office is to engage our state partners. Improving quality and cost of care for Medicare and Medicaid enrollees relies on effective partnership with states because we share the responsibility to provide care and to finance that care for this population. Our office has recently announced 2 key initiatives that support our state partners in improving care coordination for Medicare and Medicaid enrollees. One of these initiatives was the establishment of a new process for states to access Medicare data for care coordination purposes. Lack of timely Medicare data, particularly Part D data, has been a key barrier for states in expanding care management efforts for their dual population. These data provide states with a powerful new tool to support their efforts to improve care for some of their most complex and costly beneficiaries. The second initiative, done in partnership with the Center for Medicaid and Medicare Innovation, is the state demonstrations to integrate care for dual eligible individuals, under which 15 states were competitively selected to design new approaches to better coordinate care for Medicare and Medicaid enrollees. Through these design contracts, CMS is providing funding to selected states to support their efforts to design person-centered approaches to coordinate care across primary, acute, behavioral health, and long-term supports and services. The goal of this initiative is to identify and validate new care delivery and payment models that can be tested and then replicated in other states. Importantly, though, our office serves as a resource to all states and is available to provide technical assistance to any state interested in working to improve quality and reduce costs for its Medicare Medicaid enrollees. In closing, a high priority for our office is to significantly increase the number of Medicare Medicaid enrollees that have access to seamless, coordinated care. We will get there by eliminating barriers to integration, partnering with states, providers, and other stakeholders, and developing new delivery system and payment models. We expect that improved care coordination and quality outcomes for this complex population will result in better care at reduced costs for both the federal government and states. Thank you very much.
Thank you. I want to thank you for your opening statement. I'll now begin the questioning and recognize myself for 5 minutes for that purpose. Director Bella, in a 2010 paper entitled Options for Integrating Care for Dual Eligible Beneficiaries, you wrote, quote, "The goals should be clear: to provide beneficiaries with the right care at the right time in the right places, and to give states and other stakeholders the flexibility they need to design and test accountable models of integrated care." Is it fair to say that you still believe the current system does not provide states the sufficient flexibility or incentives necessary to integrate care for duals?
As I mentioned in my testimony, states are critical partners for us, and so we have to recognize the variation in the states and understand where the states are in being able to develop models to improve care for this population. When I think of flexibility for this population, I don't think of it in the context of being able to cut benefits or services. I think about it in terms of we have a population with very complex needs, and we have to be able to adapt to those needs. And by adapting to those needs, it allows us to provide more cost-effective care than might otherwise be available in the traditional Medicare and Medicaid systems when they're fragmented and not integrated. And so we see potential for integrated and coordinated systems to be able to take a holistic look at an individual, understand what that individual needs, and make sure that we're getting those needs met in the most cost-effective way.
What feedback have you received from states in your current capacity about their interest and willingness to further integrate care for adults, or duals?
It's a great question. Everyone knows states are financially strapped right now, now more than ever before, and they recognize that a tremendous opportunity to improve quality, and by improving quality, help control cost is with this population. I've seen more motivation in states than ever before to really understand the needs of this population and to develop integrated and seamless systems of care, again, that improve quality, and by improving quality lead to reduce cost over time.
As you know, there are various opinions on how dual eligibles should be enrolled in integrated care models or in coordinate care programs. Do you believe that mandatory enrollment with an opt-out policy would increase enrollment?
Certainly enrollment is a significant issue, and first and foremost I should say that the commitment of our office is really to establish beneficiary protections so that the programs we're creating are ones that are better than what are available to beneficiaries today. In thinking about enrollment is one of many issues where we have to be open to exploring options, to understanding what's keeping people out of integrated systems today. And again, this is one of the issues on the list that we're committed to exploring with our state partners.
Your office recently announced the availability of Medicare data on duals for states to access on a project basis. Why do you believe the availability of this data was so important for states, and what else can CMS do to improve the availability of real-time Medicare data for states and providers?
Well, I have a personal interest in this. I'm a former Medicaid director, and when Part D happened and Medicaid agencies lost access to pharmacy data, it was like tying their hand behind their back, because a critical tool was taken away to understand how to provide better care to these beneficiaries. So by giving states these data, we support their efforts to identify high-risk individuals, to provide the data to primary care providers and care managers who are developing care plans to understand opportunities to prevent hospitalizations, for example, or to reduce medication errors or medications that are going to have adverse effects with each other. We believe that putting the data out there for states that we have will get them exactly where they need to be. It's timely. It covers Medicare A, B, and D, and it's done in a way that allows us to protect the important privacy and confidentiality safeguards, yet still give this critical tool to states who are trying to design programs to improve quality.
Okay, I think I have time for one more question. Realizing the Medicaid expansions in PPACA do not directly apply to dual eligibles, do you believe implementation of the expansions could have a woodworking effect on the overall system that could increase the number of woodworking dual eligibles?
You know, we've not done, our Office of the Actuary has not done as detailed estimates on this as in other populations, but our early examination of the issue does not lead us to believe that there will be a woodwork effect for dual eligibles under the expansion.
Thank you. Chair recognizes the ranking member, Mr. Pallone, for 5 minutes for questions.
Thank you, Mr. Chairman. I was going to ask unanimous consent for Ms. Christensen to sit in on today's hearing, Mr. Chairman.
Without objection.
Thank you,
Order.
Mr. Chairman. I wanted to try to ask you 3 questions, or try to get in 3 questions here, Ms. Spella. My first relates to budgetary concerns. As you heard in my opening statement, I'm always concerned that decisions about dual eligibles are based on budget concerns, not suggesting that that's true for you, but I always worry that that's, you know, a big factor or maybe disproportionate to what it actually should be. And as we said, you know, it's a very complicated group. There are patients like people with developmental disabilities who may be well under 65, but you also have duals who are people with cognitive impairments like Alzheimer's disease at advanced stages. So because they're not the type of patients that insurance companies are rushing to sign up for, you know, that's another concern I have. I mean, it's a very expensive population. So I think we have to be creative and assertive in our attempts to improve care for duals, but we also need to be realistic in our goals and understand that it may be costly, and budgetary expedience should not drive our treatment of the sickest and the frailest of our citizens. So my question is, first question, can you tell us about how you and your office are thinking about the dual eligibles as groups? Are you looking at them by what kinds of diseases that they might have, or by the basis for eligibility for the programs? And of course, you know, my concern is that it's not budgetary driven.
You're exactly right. It's a very diverse group. There's a few different ways that you can think about slicing and dicing the population, and I think that's one of the advantages to having this office is we are really going to drill down and look at subset analysis of the population. One of the ways we're looking is at the highest level over and under 65 to understand the different care needs of those groups. And for example, when the under 65 population with disabilities, the presence or absence of mental illness, I like to call it a game changer. It significantly changes the utilization, the picture. On the corollary, the over 65, same thing can be said for Alzheimer's and dementia, and you'll hear more about that today. So we're looking at those levels and we're teasing out those subsets. In addition, there's also ways of looking at the population, understanding if their needs are more acute care driven. So folks who have 5, 6, 7, or 8 physical comorbidities, or if they're long-term care driven. So these are folks who have needs that are more supportive services and those types of needs. In the long-term care bucket, some of those individuals are in nursing homes and some of them are in their community. So that further distinguishes how we have to think about subsetting the population. And then we tend not to think about it by conditions or by eligibility groups. We tend to look for care opportunities. So regardless of what the profile is in many ways, what needs to happen for these patients is an assessment of their needs, is the availability of a care team, our supports to get them the most cost-effective services they need in whichever setting they need them. So just coming back to your question, those are examples of ways we're looking at subsetting the population and then using that information to drive our decisions about what types of care models, what types of care teams, what types of payment and measurement systems we would have in place.
Now I'm going to try to get 2 more things in. You mentioned the nursing home population. More than half of all nursing facility residents are dual eligibles. In 2007, more than 70% of Medicaid expenditures for dual eligibles were for long-term care. What can be done to improve the care and quality for these, you know, for people in nursing homes? I mean, are there, and what are states proposing that would help these individuals? Obviously, I'd prefer that they not be in nursing homes. So are there ways to improve care in nursing homes or get them out of nursing homes altogether so they don't have to stay in the nursing homes?
The answer to that is yes. There are ways to improve the care, and there are several states and many states that are looking at rebalancing efforts. I think you'll hear about some initiatives in North Carolina in particular to target those folks in nursing homes, but a couple of just examples. We can really focus on avoidable hospitalizations of nursing home residents, and I'll give you some examples. Urinary tract infection, pressure ulcers, dehydration, fall prevention, those are all things that are avoidable and they're preventable, and by targeting interventions and clinical resources on site, we can improve the quality of care, reduce hospital transfers, and presumably help toward the cost effectiveness challenge as well.
All right, let me get my third question is, I know that, you know, they worry about passing the buck. In other words, is the state who's responsible for their care? The state, the plan that their insurance plan, and a lot of times there's passing of the buck in terms of who takes care of them, who follows up, how to enforce their rights and fulfill their medical needs. Who's truly accountable at the end of the day for ensuring that the needs of duals are met and the quality care is provided? Is it the plan, the state, the federal government? And do you see it as part of your office's mission to clarify that to make the pathway easier? In other words, can you play a role in all this so that the buck doesn't get passed? I know I'm out of time, Mr. Maybe she can be quick in her answer.
I'll be quick. States and feds are accountable. We share responsibility. Our office is absolutely accountable, and I think the reason that it was created was to streamline care and to help make sure that we do keep the systems together and improve accountability for the program overall.
So you try to coordinate between these?
Yes.
Okay. Thank you.
Chair thanks gentlemen and recognizes the full committee chairman, Mr. Upton, for 5 minutes of questions.
Well, thank you, Mr. Chairman. Appreciate your testimony. In your testimony, of course, you said that total annual spending for their care is estimated at $300 billion annually, and that the 9 million Medicare and Medicaid enrollees accounted for approximately $120 billion in combined Medicaid, federal, and state spending in 2007, almost twice as much as Medicaid spent on all 29 million children that it covered in that year. Now, in responding to Mr. Pallone, you talked about some savings you may see in terms of targeting certain innovations. What other ideas to eliminate barriers you might think that we might be able to achieve to actually see some real savings in the program? What other innovations should we think about here?
Sure. I appreciate the question. Unfortunately, there's no silver bullet, and the savings tend to happen over time. However, if you think about, I think where we think holds the most promise is understanding how do we create systems that are accountable and coordinated for the 9 million dual eligibles. There are, by our count, around 100,000 people that are in fully integrated programs, and by fully integrated I mean there is an accountability for both Medicaid and Medicare. So the opportunity is large for the rest of the dual eligible population, and absent that coordination and integration, we're not as aligned and efficient and effective as we could be. And so there great opportunity exists to look at delivery system and payment reform models that understand how to create a way to take care of the totality of a beneficiary's needs and how to make the incentives, sure that the incentives are aligned for doing so.
Well, can we actually come up with some nuts and bolts to see not only the innovations but then lead directly to some savings? And if so, what would the savings be, either as a percentage or as real dollars? So
as was mentioned, one of the first things we did is to engage states in a partnership to work with us in the Innovation Center to design new fully integrated models. So we have 15 states. That's exactly what we're doing. We're working with them to design the nuts and bolts of what this would take. We're in the design phase, so we don't have savings estimates for you at this point. Certainly we can expect that there are opportunities, as I mentioned, in some of the avoidable hospitalizations, but we also have seen in programs in the states that do have them, oftentimes there is an increase before you see a decrease because there's a lot of pent-up demand, there's care management that's occurring, there's new services that are taking place in order to reduce other services now or down the road. So it needs to balance out. But we will be working on getting some concrete estimates over time by working with our states on the models that they'd like to do.
So as you're looking at those 15 states, how long will it take for them to complete the work that they're doing and you can actually look at some accountability in terms of what they've done?
The way we structured this demonstration initiative right now is that it's a 12-month design period. It doesn't mean that states can't submit a proposal
earlier. Which started when?
April. It started in April. Several states are interested in putting something forward earlier, and as I mentioned, all states are able to put proposals together. We're just working with these 15 to receive funding. So states aren't, like I said, they can come in sooner with ideas. We designed this because this isn't a typical CMS demonstration where we were prescriptive about what we want to see because that hasn't worked for us with the states so far. So we need to work with the states to design what's going to be most effective for each of them. However, this is a complex population and we have to do this in a way that makes sure that we are addressing significant issues around beneficiary safeguards, provider participation, financial incentives correctly, and that's why we have designed it in a design phase.
Okay, thank you. I yield back.
Chair thanks the gentleman, recognizes the ranking member of the full committee, Mr. Waxman, for 5 minutes of questions.
Thank you, Mr. Chairman. There's an interaction between the issues we're talking about today and the Medicare Advantage program is a complicated one. Some Medicare Advantage special needs plans have been around for a long time and built deep roots in their communities. Others have less successful track record, and of course the program has for a long time been supported by large subsidies provided by taxpayers and other beneficiaries. The Affordable Care Act pared back many of the extra payments to Medicare Advantage plans, but not all of them, and not immediately. I was surprised to find that some states are proposing to use Medicare Advantage benchmarks as the basis for their proposed payments in the duals integration demonstration. Ms. Bella, wouldn't the use of Medicare Advantage benchmarks increase costs to the federal taxpayer if they were adopted for duals integration demonstration?
We certainly think that, as I mentioned, I mean, our goal is to get more beneficiaries served in integrated systems. And so in integrated systems, there is an opportunity to achieve savings. You are obviously pointing out what we all have seen in terms of the differential in the MA rates. And I would just come back to that the purpose of the Innovation Center is to develop and identify delivery system and payment reforms that improve quality and reduce cost. And so as we go forward with these demonstrations, that's going to be our overriding principle. So we will work with states to ensure that the proposals they're putting in place do both of those things, which would mean understanding how we would address the rate issue in a way that would support improving quality but not add cost to the system.
Okay. Well, we want to highlight that issue to look at carefully in your design of these proposals. There are numerous cost savings with regard to the Medicaid program that shift costs from the federal government to the state governments instead of lowering costs. The intent of this hearing and the mission of the Medicare-Medicaid Coordination Office is to improve care for dual-eligible individuals, thereby lowering health care costs in Medicaid and Medicare, a better way of saving money than shifting responsibility. I want to ask about some of these contracts. You've been talking about it in response to other questions. You recently awarded to 15 states to design coordination of care models. One requirement you concluded was integrating care across primary, acute, behavioral health, and long-term supports and services. Can you discuss the importance of integrating care across all these benefits, the barriers to integrating care across all these benefits, and how prevalent such full integration is in today?
Sure. I think the importance is to get at exactly what you talked about, the opportunity to cost shift. So we need to mitigate or eliminate those opportunities. For example, if we have acute care in one system and long-term care in another system. But more importantly, if we're going to put together systems of care that are better for real people that need them, we have to provide a seamless way of them interacting with the system, rather than 3 different cards, 3 different doctor networks, 3 different grievances and appeals. And I say 3 because most of the duals are in separate Part D plans, so they are navigating Medicaid, Medicare, and pharmacy coverage. So that's the importance of putting everything together in a way that is seamless to them. The challenges are many. There are certainly always, whenever you change a system, there are concerns. We have concerns with capacity, with provider capacity, particularly within the long-term supports and services side. We have carve-outs in some states, particularly around behavioral health, so all of those issues that we need to address. But the opportunity is great, and one of the reasons these states were selected was because they are committed to providing full integration. As I mentioned earlier in response to another question, we think only about 100,000, maybe 120,000 folks have fully integrated models. You'll hear about one of those today with the PACE program. But again, our goal is to create those types of systems for significantly larger numbers of Medicare, Medicaid enrollees.
As you move forward in developing these new systems for dual-eligible beneficiaries, I think it's critical that you hear from the individuals and their family caregivers and get their input into the process to ensure that any new approaches are simple enough for these individuals and their caregivers to navigate, protects the rights currently guaranteed to beneficiaries under Medicare and Medicaid, while also meeting their health concerns. How will your office ensure that you get these voices heard from the patients and the caregivers?
Well, first of all, we share your commitment and your interest in doing that. We are very vigilant with our states on the expectations in terms of stakeholder engagement. We've gotten wonderful input from different consumer advocacy organizations about how to ensure that's meaningful. We're doing focus groups of real dual eligible beneficiaries around the country, so hearing from the real people about what's working and what's not working. Why did some choose integrated systems? Why did others not? And so those types of conversations really will be informing and driving our efforts.
Thank you very much. Thank you, Mr. Chairman.
Chair thanks gentlemen and recognizes the Subcommittee Vice Chairman, Dr. Burgess, for 5 minutes of questions.
Thank you, Mr. Chairman. In the section of the Affordable Care Act that you referenced that creates your office, there is paragraph E says the Secretary shall, as part of the budget, submit to Congress an annual report containing recommendations for legislation that would improve care coordination and benefits for dual eligible individuals. When should we expect that report?
So our office was officially created December 30th through the Federal Register, and so we missed really the typical budget cycle. In February, the Secretary submitted a letter outlining the progress of the office to date, committing to our priorities over the coming year, and then now that we are established, we'll get caught up on the regular cycle and provide you that annual report as part of the annual budget process as the mandate requires.
So when should we expect to receive that report?
Next year.
Next year, January next year.
Next year, February? February of 2012.
It's just interesting in the law that was signed, that your office was created not later than March 1st, 2010. Always interesting how something can be created 3 weeks before the bill got signed into law. Let me ask you a question. In January, Dr. Berwick was at the Commonwealth Fund symposium that they put on every year. And of course he articulated this problem, and I think he was a little more dramatic. He said 20% of the beneficiaries are costing me 80% of the money. He may have been including blind and disabled in that group as well. But that was a pretty startling figure that he related. Now, another member of Congress who was there, and I can't take credit for this, it was actually a Democrat who complained that American health care was so complicated that he had to go out and hire a concierge physician to manage his care between the two coasts on which he lived. And so I asked Don Berwick, why wouldn't you have a concierge doctor for a dual eligible? It seems like it would make a lot more sense to pay a physician to manage these conditions. I've got some figures here from 2005 where it's $26,000 a year that we spend on a Medicare, Medicaid dual eligible patient unless they have 5 or more conditions, in which case that cost doubles. It seems like there's some significant efficiencies that could be gained here through the integration of that care, whether you call it a retainer physician, whether you call it integrated primary care, but really putting the doctor and not the agency, and not a home health aide, putting the doctor in charge of that patient and holding them accountable, of course, to performance metrics that you outline, the alignment, the data, and the models and demonstrations. Why not do that?
I don't think that it's, I don't think these things are mutually exclusive. I think there are opportunities depending on what's driving a beneficiary's needs. Some of them are less medical, they're non-medical, and so it might be in those cases it does make more sense to have a care manager or behavioral health specialist or a home health aide.
But why not have a physician in charge of all of those facets of care?
There are certainly models that do that, and you may hear a little bit about those on the second panel. There are a lot of medical home initiatives underway right now, which the primary purpose is to support the physician and provide infrastructure support so that the physician is managing the totality of the care and is accountable for the financing. So I think there's a lot of promise for many of those models, and several states are exploring those very things.
Well, forgive me for seeming impatient. I think there's a lot more than a lot of promise. I think there's a deliverable that could be attained really in a much shorter time frame than anything we've heard discussed here this afternoon. And we're talking about enormous amounts of money. We're talking about people's lives, people who are medically fragile, whose care is of utmost criticality to them and to their families. And I simply cannot understand why we wouldn't move with greater dispatch. I mean, we're going to have to wait another year for a report from your office. I mean, these are things that should have been in the works for some time.
Certainly developing new delivery system and payment models is first and foremost on what we're doing. We're happy to come over and do briefings at any time, and we've done that repeatedly with several staffs. And the only other thing I'd say is, again, it's not that we're not advancing physician-directed medical home type models, but we are also looking at different types of care models, some of which are less expensive and perhaps better tied to a beneficiary's needs, which again would, I think, advance what you're charging us to do today, which is control costs.
Well, you do get what you pay for. You know, the experience with the Accountable Care Organization rules and regs that came down is just so disappointing. So many people had placed so much emphasis on this and so much importance, and then to find the reg was absolutely unworkable, that clinics who actually considered themselves accountable care organizations said, we can't do this. And I worry about the same thing happening in this population where it's so critical that we get it right.
Chair thanks the gentleman and recognizes the gentleman from Illinois, Mr. Shimkus, for 5 minutes for questions.
Thank you, Mr. Chairman. Welcome. I'm glad to have you here. Realizing that the Medicaid expansions and the health care law do not in totality affect dual eligibles, do you believe that the expansion of Medicaid, and I know you mentioned this woodworking aspect, do you fear a woodworking aspect with the expansion of Medicaid under the health care law?
We don't, no.
The latest MedPAC report included a chapter on dual eligibles. In its report, the Commission noted that a single program design is not likely to be adopted in every state. They added, there is no clear evidence about which programs are most effective for every type of dual eligible beneficiary. Do you agree that a one-size-fits-all strategy for improving the coordination and integration of care for duals is a bad strategy?
We think it's very important that we recognize that there are different delivery system designs in the states, and if we're going to be effective, we have to work with states to understand what systems are going to work best for a given state and honestly for a population within that state.
And following up on that, do you believe that mandatory enrollment with an opt-out policy would increase enrollment?
As we discussed a little bit ago, enrollment is obviously a significant issue. We don't have as many people in these types of systems as we'd like to today, so it's one that we're exploring to understand. It's one that we are learning from in the focus groups as well to understand what it is that's holding back enrollment, and that's one of the things that is part of this design process and our work with both states and stakeholders.
And part of the problem in obviously the Medicaid, the dual eligible, the Medicaid and Medicare, is that the 50-50 share of Medicaid and the ownership that the state has versus Medicare, which is the federal program. And there, the contention is, or the fear, that some states may not be motivated to help solve this based upon depriving them of the 50-50 share if Medicare is then making an, assuming more of a role or a role. Can you talk me through that and your experience in talking with states and whether this might lend itself to a sharing of Medicare as part of this debate of how you have inclusive care?
Sure. Our work with states highlights that an area that creates challenges is the misalignment of incentives between the federal government and the states. The governors have said that, NGA has said that, MedPAC has said that. This administration recognizes that. So that is part of our work with states, is to understand if we're going to get this right, we have to look at how we align the incentives to create systems of care that are better than we have today.
And I'll just end on this, and I appreciate your time. Look forward to the second panel. Illinois, in particular, is a struggling state, as many states are, but we have a $12 billion debt. A lot of it is due to the expansion of Medicaid without comparable increase in revenue by the state, and so it just was borrowed money and the like. Under the health care law, which leads to my back to the first question, it actually increased enrollment for Medicaid versus over the very lucrative program the state of Illinois already has. That's why I would argue that there should be a concern about more people coming out into the into the arena based upon the expanded benefits, and I would hope that you all would take a closer look at that, because I do think that's going to be additional liabilities for us that we're not calculating in cost today. Thank you, Mr. Chairman. I would yield back.
Just for a moment.
I would yield to Dr. Burgess.
Can I go back to the integrated care question that I was talking about just a moment ago? And so what is being done right now as far as making families aware of the availability of integrated type of care?
It depends on a given state and a given health plan. So there are opportunities to inform beneficiaries and their caregivers of integrated care options, either through state efforts or through health plan efforts. Or
Is
through
anything being done
providers.
to enroll people in integrated care programs?
Certainly, but there are two different enrollment processes, one for kind of the Medicaid half of the person and one for the Medicare half of the person.
But the estimates I have, less than 2% of all of the dual eligibles are in some type of integrated care program.
Correct.
And yet the promise these types of programs hold is high. Maybe you can get back to me with some additional information on what's being done to foster that information.
I'd be happy to do so.
Chair, thanks. The gentleman, recognize the gentleman from Ohio, Mr. Latta, for 5 minutes for questions.
Well, thanks very much, Director, for being with us this afternoon. I appreciate your time. Just a little background, because I didn't see, where were you Director at?
Indiana.
Indiana? And how long were you the Director in Indiana?
From 2001 through 2005.
Okay. I always like to just find a little bit about a person's background, because sometimes it's good to see things from the other side of the fence. I was in the state legislature in Ohio for 11 years, and during that time we had our go-arounds, especially with the cost of Medicaid going up, what it's costing the state budget today, and so I'm glad you have that experience. You know, and not that I wasn't fascinated with all your testimony, but something struck me on page 4. In the second paragraph, when you're talking about coordination of the offices, the one thing that really caught my attention was the seamless care. And I know that years ago, when I was in the legislature, I'd been a county commissioner for 6 years prior to that. We had an individual in the county that we had a lot of problems trying to get to the right service, to the right place, and I was very proud of my home county in that we worked things out, and how we termed it was seamless. And the reason I find that interesting is that how is it that it's taken this long for us to get to this point, that after decades that we're finally starting to talk about seamless, and then also in your testimony talking about the offices working to improve the collaboration and the communication out there. And again, I think that goes back that you seeing things from the other side of the fence, that for decades states have been on the receiving end of things, with the federal government saying one thing and the state saying, well, how are we going to get this done? So if I could just ask you that.
Well, a few thoughts. I mean, when these programs were created, I don't think it was ever envisioned there would be 9 million people eligible for both, and so they work exactly as they were designed to work, which is completely separately. And we haven't had the resources to date committed and accountable for trying to put them together and create seamless systems, and you all fixed that by creating this office. And so I think it's a recognition. Oftentimes it seems to be the most difficult fiscal times that drive some good developments that could help real people and coordinate care, and that perhaps is what we're seeing today. Is one of the greatest advantages of having to realize where we need to focus is on this population. And so we now have a group of people, that's all we do. And so we are accountable for making that better and working with our state partners to do so.
Okay, let me ask this, if I may, because, I hate to say it this way, that we do have some established bureaucrats in this city that have been here for a while. And, and I know in listening to your testimony and answering your questions to other members here with us today, that you're talking about doing focus groups around the country, that you're going to be listening, and that, pretty much there is no one size that fits all, because, again, like in the state of Ohio, it's completely different than maybe it's happening out in Idaho, or you name it. But I think it's going to take the direction from you, as someone that's seen it from the other side, to really impose upon these individuals down here that there is something that occurs outside this beltway. And I have folks back home ask me, I don't care what it's about. They say, don't they understand what's going on back here? And it's very difficult to always have to tell them no. And so, you know, we're going to be looking for, you know, for your guidance to make sure that these folks down here that have been here for a while understand that they do have to take that direction from you. Is what you're saying. You're going to be listening. You're going to have these focus groups to find out what works best. So with that, Mr. Chairman, I appreciate the time, and I yield back.
Chair thanks, gentlemen, and recognize the gentleman from Louisiana, Dr. Cassidy, for 5 minutes of questions.
Thank you. Ms. Bella, I appreciated our phone conversation a while ago, and I appreciate your testimony today. Now, I've been trying to figure out, you mentioned the buckets of dual eligibles and the partial duals who have versus the full duals with a wraparound. And I gather the full duals, I know I'm going to mispronounce this at some point, may have custodial care paid for by Medicaid, but medical services paid for by Medicare. And the partials will have the deductible copay paid for by Medicaid. What percent of patients who are duals are in each bucket? And what percent of the expense of duals are in each bucket? Because clearly wherever, and then what are the medical outcomes of each bucket? Because clearly if we have poor outcomes and higher expense for that, more expense and poor outcomes in a bucket, that's where we should focus our attention, yet it seems as if it should take two different approaches.
So the biggest bucket would be the full duals who are receiving all Medicaid services and Medicare services.
So now what, just not to be rude, but just so I understand. So really in the full duals, there's not that much that Medicaid is paying for acute medical services, I gather. Rather, they are paying for the custodial care. Is that correct?
They're paying for largely the custodial care. They wrap around and provide some things like behavioral health services or home health in cases where Medicare. It's wraparound acute. It's the wraparound for the cost share for the fulls, and then it's primarily the long-term care services and supports.
So okay. So then, if we can differentiate how much of the Medicaid dollar is going for custodial versus those medical services which Medicare does not pay for, do y'all have data on that? Because I'm gathering that most of the expenses on the custodial care, which is relatively non-compressive.
I would call it long-term care supports and services, just because people tend to think of custodial as institutional based. So 70% of costs are in the long-term care bucket, if you will, for those folks.
For the full duals.
Yeah, but again, that's not just the custodial care payments to the nursing homes.
So then, if you separate out, okay, so Medicare and Medicaid together, the duals are a higher percent relative to a cohort, non-disabled cohort.
Yes, yep.
Okay, so if you just look at the non-medical cost, assume non-long-term care costs for those duals, how does that relate compared to a cohort? Do you follow what I'm saying?
So on primarily their Medicare expenditure?
Yes.
Yes, they're still higher across the board.
Is it as dramatic? I mean,
it's fairly dramatic. I mean, if you think about they're qualifying for both Medicaid and Medicare, so they have not just the medical needs, but they have a lot of psychosocial complexity.
Now, then let me ask you, we're going to hear about a PACE program, and I've been very impressed with the concept of PACE, but it clearly is not going to scale. I'd like your perspective on why a program such as that is unable to go to scale.
Well, PACE is designed for a very frail population, so a couple of things. One is PACE is for people who are 55 or older, and you meet a nursing facility level of care. So again, that's a very, very frail population.
But that must be your highest expense population.
It is a high expense, although, yes, it is a high expense.
And there must be a heck of a lot more of them than 20,000 people, or 100,000, or whatever.
There are opportunities that Sean will discuss, and they've been thinking about how to get this something that's available to more people in more states. It tends to be resource intensive to get some of the programs started, but it has very fundamental concepts that we want to replicate. Well, within
I accept that. It's got great concepts, but again, but it's been, and I say this not to diss, but rather to say that's disrespect for the, but rather it just hasn't gone to scale.
Yes, he's going to get into it a lot more, but I'd be happy to have another conversation with you offline.
The ACO rules, which are just, place great faith in supercomputers to contact, to follow different patient interactions, physician interactions, I almost see as being counterproductive. It almost, have you read the ACO rules and thought about how they're going to apply to dual eligibles?
I have to be honest, I haven't read every single page.
Oh, I
However,
understand
I've
that.
read a majority and have been thinking about how do you take that model for folks that have long-term care, not just acute care needs, and that have two different funding streams, both Medicaid and Medicare, and make sure that we're creating a system that, again, doesn't provide opportunities to
But I understand that's what your approach is, but what I've just gathered from you, most of the Medicaid expense is actually on the long-term care aspect of it, and the ACO is going to be principally on the acute medical services. And that way, the ACO still doesn't dictate or assign or anything else, it just follows. I think you can answer that question. The following, it still seems like that's what we have now. You just merely follow and pay a lot of money for discoordinated care.
I think that we're excited about the opportunity to work with our states. Again, we're thinking about how do you adapt a more of a managed fee-for-service approach that has an accountability like an ACO that brings in the long-term care side for this population.
Thank you. I yield back.
Chair thanks the gentleman and recognizes the gentleman from Kentucky, Mr. Whitfield, 5 minutes for questions.
Thank you, Mr. Chairman, and Ms. Bella, thanks for being with us today. When the Affordable Care Act was passed, the method used in passing it created a lot of animosity, much of which is still out there. And I'm assuming that you were not even working at CMS when it passed. But the method used, for example, when it was on the House floor, this bill is 2,500 pages, whatever it was. We were not allowed to even offer one amendment. So I contrast that sort of process to deal with a complicated healthcare delivery system that has a lot of problems with what you're doing in your coordination office, in which you're giving $1 million to 15 different states for the purpose of allowing them to explore, be innovative, and see if they can come up with a system that works so that it could be replicated in other states, which I think is commendable. But that same suggestion has been made for Medicaid regarding the grants to the state, or a lot of controversy in the Republican budget was we will have a capitated system for Medicaid. My question would be, don't you think that there would be some merit in working out a system so that individual states on Medicaid could explore, be innovative? I know we're not talking about dual eligibles per se, but the Medicaid program, do you see any benefit by setting up a system that would work like that?
We're really kind of singularly focused on setting up coordinated and accountable systems for dual eligibles and making sure that there are beneficiary protections, access to care, and funds sufficient to provide care in such a way that eventually helps with the cost conundrum.
But at least you all are doing that with 15 states, so, I mean, I think that's a good idea. I'd like to yield the balance of my time to Dr. Burgess.
Thank you, Mr. Whitfield. If I could, let's just go back to the fact that the spending per dual eligible in 2005, $26,000, unless they had 5 or more conditions, in which case it doubled to $50,000. Obviously, more medical conditions are going to cost more, but it seems like that amount is greater in the dual eligible realm than it is for the comparable Medicare patient with 5 or more chronic conditions. Is that a fair statement?
Across the board, dual eligibles rate higher than Medicare-only beneficiaries, yes.
So is that increasing cost only because of the cost of long-term care, or is there something else that's entering into that? What accounts for that cost differential?
Well, this is a much more complex population, and so the needs that they have and the way those needs translate into utilization of services is what drives cost. I mean, across the board, again, this population is poorer, sicker, more impaired than any other population we serve.
Correct, which is why my anxiety about not having a knowledgeable medical person in charge of orchestrating all aspects of that care. If you don't have that, then you're going to get what you've got. And the last thing we want is more of what you've got, because we haven't got any more to give to pay for more of what you've got. Do you follow me? I mean, this is so critical that we have the knowledgeable medical person in charge and responsible for that patient's care. The elderly patient in a nursing home doesn't just get a urinary tract infection, they get urosepsis. And they come into the hospital and they die after 5 days of intensive therapy. The outcome is just absolutely dreadful, and it costs a lot of money. Someone to be able to anticipate that and prevent that is literally worth their weight in gold in that situation. Is that not correct?
We are trying to create systems where there is an accountable care team and an entity that
You don't need a team. You need a person. You need one person to be accountable. I mean, I'm sorry. I mean, I'm old school. I'm a doctor. And in the old days, there was one person in charge and accountable. Mr. Chairman, against my better judgment, I'm going to ask that this Ezra Klein article from the Washington Post from June 16th be entered into the record. Only about half of it is accurate, but the part that is so accurate that I think it is. I think it's worth sharing with our colleagues and the general public. What's that? Well, let me redact the part that's inaccurate.
Without objection?
Thank you.
So ordered. All right, Chair thanks the gentleman and recognizes the gentlelady from the Virgin Islands, Dr. Christensen, for 5 minutes for questions.
Thank you, Mr. Chairman, and I thank you and the ranking member for allowing me to sit in on this important hearing. And I'm particularly interested in being here because in the dual eligible population, somewhere around 40% of that population are minorities. And so I hope, Director, that you're also working with the new Office of Minority Health to look at that subpopulation as you plan this coordination. So the dual eligible population then disproportionately suffers from racial, ethnic, as well as geographic disparities. And these are particularly pronounced in the end-stage renal disease population. There's been a successful, I think, completion of a 5-year coordinated care demonstration for end-stage renal disease patients. And what are your thoughts about expanding this demonstration to the dual eligible population? Is this something that your office and can work with others to implement?
We're certainly interested in looking at all demonstration opportunities that could be tailored to the dual eligible population for different subsets of the population. So it's certainly something that we can go back and discuss further with our colleagues.
Okay, I think it might prove helpful, especially since end-stage renal disease, I'm sure, accounts for a lot of the cost that Medicare puts out. Also as a provider, like Dr. Burgess, and having worked with American Health Mercy family of companies, which is one of our country's largest Medicaid managed care plans, to help understand some of the challenges. I understand that under current regulations, services provided to Medicaid health plan enrollees by institutions are not counted in determining payments to providers. And this results in fragmented care because states often choose not to enroll these populations into Medicaid health plans, or they carve out provider services from the plan's benefit coverage. Are you familiar with this problem and barrier to enrollment, or expanding enrollment, and are there any plans to address this?
It's certainly something that we've heard from some states and some plans. And again, kind of taking that list of everything we have to begin to understand and figure out how we're going to address greater opportunities to promote alignment, that would be part of what we have on that list.
Okay. Just one more question. In Ms. Hewison from Community Care of North Carolina, in her testimony, one of the things that she notes is that programs targeting at-risk pre-duals may be something to really start looking at, not only for the care of those patients, better care of those patients, but also for the larger budget impact. Is this something that the office is working on?
Absolutely. There's a huge opportunity with the pre-duals, particularly preventing their decline or their spend down of resources and being smart about how we can make an investment on the front end and prevent migration into dual status. So yes, it's something that we're looking at.
Thank you, Mr. Chairman.
The chair, thanks to gentlelady. Do you want him to do it?
Mr. Chairman, could I ask unanimous consent that Mr. Markey be allowed to participate in the subcommittee today?
Without objection, so ordered. Do you want to ask questions of this panel?
Mr. Chairman?
All right. Chair recognizes a gentleman for 5 minutes for questions.
I thank you, Chairman Pitts and Ranking Member Pallone, for holding this hearing. And I'd like to thank Melanie Bella for helping to lead the charge at CMS to improve care for 9 million patients who, by definition, are the sickest, poorest, costliest individuals covered by either Medicaid or Medicare. The landmark healthcare law included language that I authored to create a pilot program called Independence at Home to address the unique needs of Medicare patients who have multiple conditions, including Alzheimer's, Parkinson's, etc. Caring for these patients is disproportionately expensive, yet this population often receives substandard and uncoordinated care that produces conflicting diagnoses and confusing courses of treatment. Further, many of these individuals wish to remain at home rather than nursing homes or hospitals, and they could do so if they were given some help. The Independence at Home program gets at the root of the problem by creating teams of healthcare providers who will work together to coordinate care for these patients and provide primary care services at the patient's own home. If they succeed in lowering costs beyond 5%, the providers will share in the additional savings. So there is a stake in lowering costs to the system. It seems to me that Independence at Home could also help us improve care for the patients who are eligible for both Medicare and Medicaid by integrating health care services provided by Medicare with long-term supports and services provided by Medicaid. For years, we've seen the success of Independence at Home style programs at more than 250 VA locations and elsewhere throughout the country. The VA programs have reduced nursing home care by 88% and reduced overall costs by 24% on the highest cost chronically ill patients, all while achieving record high patient satisfaction rates. Elder PAC, which has been operating this style of program for the dual population, shows savings to the Medicaid program of 23% over the past decade. So let me ask you this, Ms. Bella. In light of the fact that the Independence at Home model has proven successful in lowering costs and improving outcomes among some of the most challenging Medicare patients, don't you agree that your office should look at expanding this model of patients that are eligible for both Medicare and Medicaid?
Well, first of all, we thank you for your leadership and support on this issue. We're very committed to models that allow dual eligible beneficiaries to stay at home with supports. We're in discussions with our colleagues about the Independence at Home demonstration. As you know, it's still in development. It'll be available the 1st of 2012. And we are looking for opportunities to make sure that it's in the mix of models that could be considered for dual eligibles.
Okay. Is there, in your experience, a reason to believe that this is a good way of looking at how we keep these Alzheimer's and other patients at home longer and save the system money because they don't have to go to nursing homes?
Certainly, we're very interested in models that allow individuals to stay in care preferences that are of their choice and that are also cost effective. And so we do believe a model like this holds promise. Again, we look forward to understanding how we can adapt that in our work with states and others as we develop new delivery system models.
Mm-hmm. And do you think that it makes some sense to incentivize the healthcare providers that they make money if they can figure out ways of saving money and by keeping patients at home? Do you think that that will incentivize them to think anew about how to take care of these patients?
Well, we always want to make sure that there's appropriate beneficiary safeguards in place and that people are getting the services that they need. Mm-hmm. But opportunities where we know that there are opportunities to align incentives, it certainly is a direction that the agency has been heading in terms of being able to do some performance-based outcomes payments.
You know, I did that bill in conjunction with the Alzheimer's Association. As you know, there are 5 million Americans right now with Alzheimer's, and 15 million baby boomers are going to have Alzheimer's. So it's obviously important that there be a plan that coordinates with families, who are the principal caregivers, so that they can have the maximum amount of help at home. Because once they go to a nursing home, it's $60,000, $70,000 a year on Medicaid, for those families. So this is just a program that obviously is meant to help to keep them at home, save the system money, make the families happier, and the patient as well in a setting where they'd feel more comfortable. So we thank you, and I'd like to continue to work with you on developing that program.
Be happy to do so. Thank you.
Chair, thanks to gentlemen. That completes round one of questions. We have one follow-up question. Dr. Cassidy.
Ms. Bella, I should know this, and I don't. I apologize. But you've mentioned a couple times that that mental health issues are going to, it's an independent variable, it sounds like. You do a retrogression analysis, and it comes out mental health is a big issue. So a couple questions. Is this related to addictive disorders, or is it related to, if you will, classical mental health issues, number one? So for, paranoid schizophrenia, for example. Is the issue that they're non-compliant with medical services and are going in and out with poorly controlled comorbidities, or is the issue that they're going in and out with mental health admissions? Clearly, it seems as if that would be something that a wraparound managed care organization could theoretically improve outcomes and strengthen stability of the program's finances. What is the track record of such programs?
I'm going to try to take your questions in order. So the first, when we think about the folks that have behavioral health issues, it's mental illness, it's also substance use. There tends, as you know, from treating patients, there's a higher prevalence of substance use in folks.
So that's a third category, if you will,
yeah,
combined.
Yep. But a lot of you have the serious mental illness, schizophrenia, bipolar, and then you have folks that have depression and other symptoms. Clearly, the utilization is different for those populations. What drives part of the trouble is tends to be a disconnect in the physical and behavioral health systems, as you know, and a real lack of information sharing, so that one half doesn't know what the other half is doing with regard to this patient. And again, as a practicing physician, you understand why that would be so detrimental, because the effects of each...
Now again, that's why it just seems like managed care would be custom made, that this is where it would integrate and bring things together.
Certainly, there's been different... states have tried different approaches. Some have given responsibility for everything to a health plan. Some have carved out behavioral health services to a health plan, while physical health services have stayed in fee-for-service. Or sometimes physical health services have gone to yet another health plan. So there tends to be different mechanisms states have tried. There also have been a couple of really great pilots, one in Pennsylvania, that it was within a fee-for-service system, but what they focused on was sharing information and aligning incentives between the physical health and the behavioral health world, and that made a huge difference. So
now, that was not managed care. That was just, there must have been some integration between the practice groups.
There was management on the behavioral health side. It was fee-for-service with kind of a PM overlay on the physical health side, but no structural or organizational integration, if you will. And it all got down to really understanding, making sure all people involved in that care had a clear picture of what the beneficiary was getting on both sides.
Now, they couldn't have been doing that with Medicaid rates. They must have been paying Medicare rates to providers, correct? Because that would be time-intensive to transfer that.
It was time-intensive. They had some outside support during the pilot phase.
They did.
But also, they got smarter about how they delivered care. They used other types of practitioners. They did a lot with peer support specialists. And the cost dynamic is different when you can provide...
Do you have an analysis of that you could share with us? Because I think that's very intriguing.
It is. I'm not sure that any final sort of journal-ready analysis has been published, but I'd be happy to share with you what's been done to date, and certainly some descriptive analysis and the metrics that they're using to measure.
Sounds great. And my second question, which was, since we went to the third, is it the increased expense due to multiple admissions for mental illnesses for the paranoid schizophrenic, for example, or is it non-compliance with medical illnesses so that they just bounce in and out because their diabetes is poorly controlled, for example?
It's hard to generalize. The population, both. But clearly, two things that both could be improved with integrated, coordinated, and accountable systems.
And you have any idea of the, that'll be a follow-up question but at a later time, but I'd be interested, again, I'm trying to understand which of this is compressible.
Yep.
Long-term care is not as compressible, whereas perhaps this would be. Yep. What % of the increased expense is related to this subgroup of populations, those with mental health and physical health issues simultaneously?
We'll call that our bucket analysis, and we'll work on getting you some analysis in those different categories across the board for the committee's consideration.
Chair, thanks, gentlemen. We have a follow-up question from Dr. Christensen.
Just very brief question. As you know, the territories with a Medicaid cap and not all of the help for Medicare either really have struggled to provide services for our dual eligibles. So I just wanted to know if this process of coordination, if your office also looks at this issue in the U.S. territories.
Our office is intended to be a resource for the states and the territories who are interested in improving care. So yes, we are available to work with the territories, absolutely.
Chair thanks the gentlelady. That concludes panel 1. Chair thanks the director for excellent testimony and yields the ranking member for unanimous.
Thank you, Mr. Chairman. I would ask for unanimous consent to submit for the record the first report that Ms. Bella's office submitted to Congress as required by the ACA, that one member, I think Dr. Burgess, was asking about.
Without objection, so ordered.
And then I'd ask unanimous consent to enter the statement of Mary Kay Henry, who's the president of SEIU. And I think you have both of these.
Without objection, so ordered.
Thank you.
Thank you. At this time, I'll ask the second panel to come forward. And I'll introduce them in the order of testimony. Robert Egge is the Alzheimer's Association's Vice President of Public Policy and Advocacy. Billy Milwee is the Associate Commissioner for Medicaid and Children's Health Insurance Program at the Texas Health and Human Services Commission. Denise Levis-Hewson is the Director of Clinical Programs and Quality Improvement at Community Care of North Carolina. And Sean Bloom is the President and CEO of the National PACE Association. Your written statements will be made part of the record. Ask that you would summarize each of your opening statements in 5 minutes before the question and answer period. And at this point, Chair recognizes Robert Egge.
Good afternoon, Chairman Pitts, Ranking Member Pallone, and distinguished members of the subcommittee. I am Robert Egge, Vice President of Public Policy at the Alzheimer's Association, and I thank you for the opportunity to appear here today. I want to begin by telling you about John and his wife, Emma. John and Emma are an elderly, low-income couple who depend on both Medicare and Medicaid. John has Alzheimer's disease and diabetes. John's physician has been consistently attentive to his diabetes, but not to his Alzheimer's. He's given John good diabetes treatment plans, but because of John's impairments due to his Alzheimer's, John has been increasingly unable to comprehend or follow those instructions. So despite his physician's efforts, John's diabetes and his overall health has steadily deteriorated. For her part, Emma has been ill-equipped to help John manage the demands of his dementia and his diabetes because of her own health and the lack of caregiver training and support that's been offered to her. Because of all of this, John and Emma began taking frequent trips to the hospital ER, where John was regarded as a non-compliant, difficult diabetic. Most of the hospital staff did not seem to recognize John's dementia, and that his non-compliance with diabetes treatments wasn't about John being obstinate or unmotivated, but was due to his inability to self-manage his care. Those that did recognize the presence and the implications of his dementia were at a loss for what to do about it. So John continued to show up at the emergency room for diabetes-related conditions at ever more frequent intervals. Each time he was sent home with discharge orders, often explained to him, without Emma even present, that he had no hope of following. These ER episodes were disconnected from his physician's care. John's hospitalizations increased, his health deteriorated, claims to Medicare and Medicaid mounted. Reluctantly, John and Emma decided he could no longer live in his home but had to enter a Medicaid-funded nursing home much sooner than either of them had hoped or expected. As reported in the Alzheimer's Association's 2011 Alzheimer's Disease Facts and Figures, there are an estimated 5.4 million Americans like John with Alzheimer's, currently a terminal disease with no known means to prevent, stop, or slow its progression. And there are almost 15 million unpaid caregivers, many like Emma, who help care for them. Those millions of Americans with Alzheimer's form a disproportionate share of the dual-eligible population. 61% of dual-eligible individuals are cognitively or mentally impaired. Nearly 1 in every 6 dual eligibles has Alzheimer's disease or other dementia. Alzheimer's and other dementias are also extremely prevalent among dual eligibles in nursing homes, where 59% of residents live with these conditions. Similarly, at any point in time, about 1/4 of all hospital patients aged 65 and older have Alzheimer's or other dementias. So this population of duals with Alzheimer's is large in scale, and it's also very large in cost. Medicare payments for beneficiaries with Alzheimer's and other dementias are 3 times greater than for comparable beneficiaries without these conditions, and Medicaid payments are 9 times higher. These facts lead to the first of 2 points that I want to conclude with today. Individuals with Alzheimer's that depend on Medicare and Medicaid make up such a large, vulnerable, and cost-intensive share of the dual-eligible population that policymakers should focus on these beneficiaries in pilots, demonstrations, and broader system reform efforts, recognizing this group as offering a leading opportunity to improve care while controlling costs. The other major point I want to close with is that focusing on improving care for dual-eligible individuals with Alzheimer's won't only deliver benefits for these millions of Americans, but will also help beneficiaries more generally. Over the years, our growing awareness of the significance of manageable chronic conditions like diabetes has led to an important emphasis on prevention, self-management, and patient-centered care. Today, in a similar way, our growing awareness of the widespread impact of cognitive impairments due to Alzheimer's and other causes should draw much-needed attention to themes such as reducing program complexity, the detection, diagnosis, and documentation of medical conditions like Alzheimer's, and to putting in place care plans that recognize not only an individual's cognitive abilities, but fully recognize and support the critical role of the unpaid family caregiver. The foundation of effective care is in diagnosis, care planning, and medical record documentation, principles contained in Mr. Markey's bill, the Hope for Alzheimer's Act, which the association strongly supports. Moreover, the insights underpinning this bill apply across the dual-eligible and Medicare populations. So again, thank you. The Alzheimer's Association greatly appreciates the opportunity to address these issues, and we look forward to our continuing work with the subcommittee.
Chair thanks the gentleman. Recognize Mr. Milwee for 5 minutes.
That might be better. I'd like to spend a few minutes speaking to you about the STAR Plus program. The STAR Plus program is a capitated managed care model that integrates acute and community-based care services for the age-blind and disabled population in Texas. This includes the dual-eligible members. A little bit about the Texas Medicaid population. There are about 3.2 million people on Medicaid in Texas today. Of that number, about 700,000 are classified as age-blind and disabled, and of that number, about 400,000 are duals. ABDs represent about 25% of the Medicaid population, but approximately 58% of the total Medicaid cost. Where did STAR Plus originate? STAR Plus originated in 1998 as a pilot in Harris County in Houston. It was created largely to address concerns about cost, quality, and access to services for the age-blind and disabled population, also the subset we refer to as duals, and to address how we could better integrate acute and long-term care for that population. The program started with about 58,000 people in 1998. Today, STAR Plus now serves 42 Texas counties and 257,000 people. In March 2012, the program was expanded to serve another 370,000 people in Texas and 80 counties. And here's how the program works at a very high level. It's an integrated care delivery model in a capitated managed care environment. So we take acute care services and long-term care services and bundle those together, deliver them through the HMO. Central to that model is a primary care provider and a service coordinator who really work with that patient to get them the services that they need, whether those services are acute care or long-term care. The service coordinator is responsible for assessing that person's need and ensuring that the needs are met. And by doing that, it provides that early intervention so we keep people out of the hospital, out of the emergency room, and out of the nursing institutions. Several studies to date by our external quality review organization have shown the model is effective. We've decreased inpatient services, hospitalizations of about 22%, reduced ED visits by 15%, and more importantly, people who are involved in the program report a high degree of satisfaction with the program. We're excited about the opportunity now to work with CMS on how we can better coordinate care, and look forward to working with Melanie Bella in her program that she just started. That's
Chair, thanks to the gentleman, and recognizes Ms. Houston for 5 minutes.
Good afternoon, Chairman Pitts and Ranking Member Pallone and the other distinguished members of the subcommittee. I'm Denise Levis Houston. I direct the clinical and quality programs for Community Care of North Carolina, and I appreciate the opportunity to tell you about our program. It's a collaborative organization of regional networks of healthcare providers, physicians, hospitals, health departments, social service agencies, and other community organizations. Each network is a nonprofit organization, and I work for the central office that helps coordinate and provide supports to all of the 14 networks. We create medical homes matching each patient with a primary care provider who leads an interdisciplinary team, professionals who coordinate seamless medical services aimed at producing better outcomes. Our challenge is not only to improve the quality of care, but to cut costs without changing benefits and fees. As you start looking at changing the benefit package and fee structures, oftentimes you're pushing the patient into other delivery areas like the emergency room. You need engaged providers to do this program and engaged patients to be successful. Sustainable savings come only from learning to deliver care in a smarter and more coordinated way. We've been doing this for 10 years. We started as a pilot in 1998. And we've been adapting and refining this model, most recently really targeting the highest cost and highest risk. What's different about our program is it's led by physicians who are charged with changing the face of healthcare at the local community level. It's a bottom-up governance. It's key to getting buy-in at the practice level. We've begun to make some significant changes in local delivery systems. It's built on a model where each patient has a medical home. We have 1,400 medical homes across North Carolina. In our 14 networks that provide the infrastructure to provide wraparound support to the medical homes, we have about 600 care managers. We have 30 medical directors, 14 network directors, 18 clinical pharmacists, and 10 local psychiatrists. These are local people managing local patients and driving improvements in their systems. The physicians are engaged because they're part of the solution. They lead the local teams. They decide how to collaborate best to get the best results. Efforts to improve care and save money are owned by those who directly provide that care. Our care managers know their patients, they know the community and the resources, and that varies greatly in some of our rural communities. Care managers are the boots on the ground. They connect the dots between the patient, the physician, the specialist, the hospital, home health, and other community resources. We believe that all health care is local and that community support for individuals with multiple chronic conditions can significantly improve health outcomes. One of the challenges in this program is defining the impactable population. You have to have the information and data to go after those patients and manage them and provide the right support so that they can have better outcomes. We serve over 1 million Medicaid recipients. We started as a Medicaid program. Now we have about 80,000 duals that are enrolled with our program. In addition, about 180,000 of those are age-blind disabled. So those represent a fairly large, significant, high-cost patients. We get hospital data. Hospitals and community providers are partners in this organization. To manage these individuals, you have to follow them across different providers and delivery systems. We hope that this committee will look hard at better aligning Medicare and Medicaid services at the patient and community level, allow for shared savings and a per member per month management fees that provide patient management without capitation or risk models. We are a fee-for-service system. The delivery system must be patient-centered. The important thing to remember is that patients need changes over time, so a system must follow their needs across settings and providers. Our community-based medical home and network infrastructure focuses on population management strategies, and we aim to achieve the triple aims that we hear a lot in the literature, which is not only about improving quality, access, and reliability, but reducing the cost of that care. We've learned some key lessons in North Carolina with the dual population, and you've heard it by several of the other testimonies today, that they have multiple comorbidities. They use the system more than a lot of other populations. They take a lot of medicines. And so they truly do benefit from a wraparound support at the community level. Our total annual budget for community care is about 1% of the total Medicaid costs in North Carolina. Our commitment to quality doesn't just mean better care, it also leads to significant program savings. We asked the analytics company Trio Solutions to help us estimate savings, and they've done that, and you've got more information at that in some of the handouts. Our trend data is fairly significant in terms of cost and savings. Mr. Chairman, I'd like to thank you and the members of your subcommittee for the opportunity to be here today and discuss these issues, and we hope we can be a resource to you as you move ahead.
Chair thanks the gentlelady and recognizes Mr. Bloom for 5 minutes.
Thank you very much, Chairman Pitts, Ranking Member Pallone, and distinguished members of the subcommittee. I'm Sean Bloom, CEO of the National PACE Association. On behalf of NPA and its members, I'm honored to testify today, and I appreciate the time that you've allotted us. I'd like to kind of focus on 3 things. Very briefly describe PACE to you, and then offer some suggestions regarding ideas with respect to overcoming barriers that we've identified in expanding PACE. And 3, identify some voluntary demonstration programs that we've generated in which we could expand the availability of PACE to additional eligible categories of dually eligible. First and foremost, PACE is a fully integrated model of care that exclusively serves the frailest, oldest, and sickest subset of the duals, that is the nursing home eligible seniors. We do so in a manner that is really focused in the community in the sense that we're community based. Our goal in PACE is to allow individuals to remain living in their homes in the community. We do that through reducing nursing home use, reducing hospitalization, and we do that in a comprehensive fashion through integrated use of Medicare Medicaid bundled payment, and at the heartbeat within PACE is the interdisciplinary team, or the concierge team, if you want to call it that, in the sense that they are fully employed staff that on a daily basis are involved in the care, delivery, and management of the care of the individuals that we serve. And the third key feature of PACE is we're accountable. We're accountable in the sense that we're accountable to government for the payment provided to PACE, 90% of which comes from Medicare and Medicaid, and we're accountable to the families and the frail elderly we serve. And I think those 3 things taken together have very effectively aligned incentives for PACE. We are fully accountable for the cost and quality of care that we directly provide. So to the extent that we do a good job, those that we serve are able to stay out of the hospital, in their homes, and achieve good health care. I think recognizing the effectiveness of PACE, a recent June 15 MedPAC report states, quote, fully integrated managed care plans and PACE providers offer the best opportunity to improve care coordination for dual eligible beneficiaries across Medicare and Medicaid services. Authorized by the Balanced Budget Act of 1997, we've been around for 20 years. We are a tested model of care, and we're very interested in finding ways to kind of grow. I think as what's been mentioned earlier, I think Melanie mentioned it, there have been significant obstacles to PACE growth, and we'd like to kind of talk just a minute about those now. One, some of the regulatory requirements certainly focus on the required process of care rather than the outcomes of care, and those particular regulatory requirements have so far hindered growth, innovation, and efficiency in how we deliver care. 2, fairly significant capital startup costs and long lead times for programs that accept full financial risk for a population that on average is about 300 people. That's a significant undertaking. And our eligibility for PACE is very narrow. We serve, as I mentioned earlier, a very small subset of the duals, 55 years of age or older, and you have to be nursing home eligible. We believe that there's opportunities to expand the availability of PACE. So to overcome these barriers, we recommend the following modifications to the PACE statute and regulation, and this is based on a decade of operational experience under the current regulation. 1, allow us to more appropriately use contract community-based physicians rather than full employed physicians. 2, take full advantage of the state license capability of nurse practitioners and physician assistants to practice up to their level of standards within the state practice acts. And then without compromising PACE participants' receipt of comprehensive care and assessment, allow more flexibility to personalize and individualize the use of interdisciplinary teams based on the individual's needs, not using a one-size-fits-all approach. And lastly, allow states, and this is something of great interest to PACE providers right now, really begin to look at states and encourage them to see PACE as a means by which to pull people out of nursing homes. Some of our PACE programs throughout the states without great state support have had the ability to do that. With respect to voluntary demonstrations, we have 5 ideas with the goal of kind of expanding PACE and finding additional regulatory modifications. One, we'd like to expand the availability to PACE to individuals under the age of 55 that are nursing home eligible. These are typically the physically disabled individuals that we believe would benefit from PACE. Two, allow at-risk or what we call high-need, high-risk, high-cost beneficiaries to have access to PACE, many of which are not currently nursing home eligible, but we believe would benefit from PACE services. Three, reduce PACE organizations' reliance on the PACE Center, which is really the focal point for the organization of services, but not necessarily the need to kind of do it all there. Fourth, the ability to kind of implement alternative approaches to providing Part D drugs. Right now, we have to implement Part D in the context of a very small program. This benefit was designed for large health plans. And lastly, a demonstration with the objective of increasing Medicare-only beneficiaries' enrollment in PACE. Currently, about 90% of all beneficiaries in PACE are duals, but we believe it's a model of care that should be applicable to others. If I had more time, I could give you a great story about the actual benefits of PACE to a consumer, but unfortunately I've run out of time. But we appreciate the opportunity to testify before the committee. And as mentioned before, PACE is a tangible, proven model of care, and we look forward to working with the committee to find ways to expand its reach. Thank you very much.
Chair, thanks the gentleman. Thanks the panel for your opening statements, and we'll now do a round of questioning, and the chair recognizes himself for 5 minutes for that purpose. Mr. Milwee, as you know, states are generally not informed about hospitalizations or prescription drug information for dual eligibles. How important is Medicare data to states in coordinating care and reducing costs associated with dual eligibles?
Well, you're certainly correct. Without that data, we can't know the health condition of the dual eligible member, and I think it's going to be critical as the Center for Medicare and Medicaid coordination forms to provide states with that data so that we can implement the disease management programs that can be more cost effective if we were to have that data.
How does Texas share in the savings generated through the STAR Plus program with the federal government? How important is it for states to be able to share in the savings generated by integrated care program for duals?
Well, today we don't share in that savings. The program was put in place to serve the population absent the need to share in that savings, and it's been recent that CMS was open again to discussions with the state about potential gain sharing arrangements. So as we get that Medicare data, we believe that we can take to CMS a proposal that will demonstrate that STAR Plus has created savings not only for the state on the Medicaid side, but also for the federal government on the Medicare side. So we'll be developing a proposal to take to CMS.
Thank you. Mr. Bloom, you wanted to talk about the benefits of PACE to consumers. Please explain in more detail your idea to modernize the PACE program to include alternative settings of care, and why is the facility requirement a burden on the program today?
Yeah, you know, I think historically, the PACE program, if you drive by PACE program, you'll see what appears to be a very large day center within which there's space for a medical clinic, rehab, social services, personal care, and possibly a kitchen. It's been a very convenient kind of focal point of care organization and delivery, but what we've discovered over time is that the ability of PACE to grow is somewhat geographically constrained by the center. To the extent that we could begin contracting out, for example, for day center services using existing infrastructure down the street by an existing daycare provider would allow us to grow the program without undertaking significant capital cost in setting up a new center every time we want to expand our geographic market. That's but one example, and I could certainly offer you more.
Thank you. Ms. Houston, you note in your testimony that the CCNC could have saved the state of North Carolina approximately $1.5 billion between 2007 and 2009, and that 100% of all Medicaid savings remain in the state. How are those savings shared with your organization?
At this point, they're not shared. It goes back into the Medicaid budget, but we have been able to maintain provider fees at 95% of Medicare. So in a way, that's a way to provide the infrastructure building and sustainability. But the money goes back into keeping the Medicaid program and dealing with the state budget issues.
Do you have more information on what portion of those savings are associated with the 80,000 dual eligibles you serve?
I don't have it on hand, but we could certainly get that information for you. We are missing some of the Medicare data to be able to tell a complete story on the duals at this point.
How are the duals enrolled in your program? Is that mandatory enrollment?
It's voluntary. typically they're going to a provider that's participating with us, and oftentimes it's the provider that encourages them to enroll, because they can then provide the wraparound support service of the care coordinators.
Are the other 220,000 duals in North Carolina mostly served through fee-for-service, or are there other coordinated care programs in the state to serve those duals?
We have I think 2 PACE programs and several in application, and then there's the Medicare Advantage programs, a few of those, but primarily the rest are in fee-for-service.
Thank you. Mr. Agee, in your testimony, you note several beneficiary examples where the complexity and fragmentation of the system prevent frail duals from gaining access to available services. You note that a fully integrated system could alleviate administrative barriers. Do you believe such a system is a one-size-fits-all, or do you believe there could be a variation of models that could be used to help improve beneficiary access to care?
We think that, first of all, there is great variety in the experience of people with Alzheimer's and other dementias. Our suspicion is that there are going to be some very important common elements that we can use in designing any kind of system. But at this point, innovation and looking at different types of approaches and how they work is very appropriate as we learn what's going to work best.
The Chair thanks gentlemen and recognizes the ranking member, Mr. Pallone, for 5 minutes for questions.
Thank you, Mr. Chairman. I wanted to ask initial questions of Ms. Houston and also Mr. Bloom. In Medicare, we've always maintained the principle that enrollment in managed care plans is voluntary for all Medicare beneficiaries. So, let me start with Ms. Houston. As I understand it, your program of coordinated care, although not a managed care plan, is voluntary for Medicare beneficiaries. Is that correct? And how does that impact the program, that it is voluntary?
Well, it is correct. I think it's by being voluntary, there's probably less enrollment than if it was an opt-out program. But typically, they're enrolling because they want to have assured access to a primary care physician that they go to, and that physician is encouraging them so that they can use the resources of the network that supports the physician in leading their care.
And then similarly, Mr. Bloom, I know that the PACE Association has long believed that it's important to have beneficiaries buy in through voluntary enrollment rather than requiring dual eligibles into PACE. Do you want to comment on that too?
Yeah, PACE, dually eligible beneficiaries have the opportunity to opt in and out of PACE, and that has been the long-standing track record within the PACE program since its inception. Having said that, we have very, very low levels of disenrollment, which I think certainly aligns the incentives for us to keep our eye on the quality and the satisfaction to the beneficiary.
And I note that in MedPAC's chapter on dual eligibles released last week, they said that many of the groups they interviewed raised concerns about access to care for beneficiaries, particularly individuals with disabilities who have established relationships with doctors already. And I just wanted you to know I support efforts to get duals into better care relationships, but we need to be careful not to take away Medicare protections for the lowest income Medicare beneficiaries because they're trying to access help through Medicaid as well. Let me go back to Mr. Bloom. We recognize that PACE is a specialized program focused on the very medically needy and a fragile population, so it's not intended to, nor it would be appropriate for it to serve, say, all 9 million dual eligibles. But currently, PACE organizations have an enrollment of about 22,000 people nationwide, and while we don't know exactly how many people could theoretically be eligible, we know it's not 9 million, but it's obviously that there are a lot more people that you could serve. You described the desire of PACE organizations to expand enrollment. So can you just tell me a little bit about what Congress could do to help PACE grow and the cautions you have about growing too fast? You know that PACE has long been supported by bipartisan members of the committee, but we want to make expansions that would work and help improve care for people and not create problems.
Very good question. Very good question. First off, I think as Melanie testified earlier, it's very important to note that the duals are a very diverse population. This ranges from the young disabled to the elderly that are simply low income, to the elderly that are frail, to older individuals with intellectual disabilities. It's a very diverse population. And I think based on our experience and an experience working with other integrated type providers, there are different approaches for different populations that we need to look at. In the context of PACE, PACE is very well designed for a very high need, very frail, very functionally impaired population. The examples I gave earlier with respect to barriers to growth were really focused on the federal side. I would argue that there are an equal number, if not a greater number, of barriers that exist on the state side. One of which, and I'll just throw it out, in this era that we live in today, you can get into a nursing home within a day, typically. It often takes you 4 to 6 weeks to get into a community-based service program like PACE. That is because of the eligibility determination process in most states, and as well as some other administrative and other obstacles that exist. That is a significant barrier for growth, in addition to some other kind of state-specific obstacles.
Well, what do you think? What's your sense of how many additional people could be helped, could go into PACE if we made the improvements, if we managed to do things that you're suggesting to change it to make it more accessible?
Good question as well. It's probably important to note we are not a health plan. At the heart of PACE is a provider. We fully employ all, I think 90% of all care is provided directly by PACE employees, physicians, nurses, and the like. So we are not going to be able to scale each individual program on par with the United Health Plan or other large commercial health plans. Having said that, we do have programs that are as large as 2,600 people. We have programs in Appalachia as small as 40. So this is a program that can move large and small. So I do think each individual program is capable of serving several thousand people, but I think you need multiple programs on the ground.
So theoretically, if you had a lot of them, you could handle a lot more people, but
correct.
They're going to have to be relatively small.
The solution to PACE growth is not to scale upon 76 that are on the ground today, but to replicate the availability of the model throughout the country. In some states, I think as the other witness testified, state of North Carolina has 2 on the ground. They're filling the entire state with PACE. They'll have 10 in development within 2 years. State of Pennsylvania is another state where there's almost the entire state's full. State of New Jersey, within 2 years, will probably have PACE available to every senior in the state. It takes a lot of leadership on the state. It takes a long-term vision. And I think it takes a strategic kind of approach to budgeting for Medicaid long-term care cost, which looks beyond the next 6 to 9 months. And that's difficult in this current era, admittedly. But I think it's possible, and you're seeing examples of that across the states today.
All right. Thank you.
Thank you.
Gentlemen's time has expired. Let me just ask each of you, what we've heard from this panel in various forms is the fact that an integrated type care model is possible, and it does work seemingly every time it's tried. Is that something that I understand? Although the programs may be different that we've heard about, they all basically involved an integrated model of care with someone being responsible for the patient. We'll start with Mr. Milwee from Texas.
Well, I think you're right. There are integrated care models out there, and what strikes me is none of these are mutually exclusive. There is no best answer. We have the Star Plus program because it works for us. We also have PACE. Star Plus and PACE can coexist, or they work well together. I'm familiar with the North Carolina model, and it could work very well for Texas in a rural area where we have Star Plus in urban areas. So I think the answers are out there. I think states have done a lot of work, a lot of innovative work on this very important issue for us because of the Medicaid expenditure, and also Medicare is going to benefit from that too. So the models are out there.
Yes, Mr. Bloom.
Yeah, I think that's exactly the answer. I couldn't agree more. The only thing I would add is that if you look at commercial health plans, which typically are the approach to integrating care for the duals, they do receive integrated financing. They attempt through their contract network to integrate care, but they do a wonderful job, I think, of improving the coordination of care for the most part. But they often will carve out long-term care risk from their payment. And that is the population we serve. So I think, as Mr. Milwee mentioned, these are programs that work very complementary, albeit for very distinct populations and segments of the duals. So if done right, I think in Texas is a good example. They have a very good vision for how they want this to roll out. It provides great hope, great opportunity, and it also provides the right, so-quote, product, service product, for the right population based on their unique needs at a particular point in time. But I do think that this is the direction to go, yes.
And Mr. Hickey, obviously the independence at home is a little bit different, but still it is care coordination. Is that not correct?
That's right. Within independence at home and other models, our aim is not to create a certain silo just for those with Alzheimer's and dementia, but to make sure that every system, like independence at home, is fully dementia capable. Many people with Alzheimer's, for instance, have greatly appreciated PACE programs and their enrollment there. So we just want to make sure that whatever systems are there, we fully recognize the importance of dealing with cognitive impairment in the caregiver.
I just have to say, your story about the gentleman with Alzheimer's who also had diabetes who accessed care at the best that they could. I mean, that's a tough thing to listen to as a physician, that someone could be exposed to that many gaps in their care in seemingly a caring and competent environment of a major hospital emergency room. That's just tough to hear. Ms. Houston?
Yeah, I agree with the other panelists. Other than I don't think just having integrated care assures that you're doing the right thing. I think you have to have a delivery system that does the right thing. And integrated care just is a way to align the incentives and the reimbursement strategies. And in North Carolina, we are not yet aligned in the reimbursement strategy, although we're one of the 15 states that will be working with the coordinated office to develop a plan along that line. But, we also have a very strong bias towards the medical home and keeping folks in the community, delivered primarily through primary care providers is probably a model that has worked really well for us.
But primarily, you do have to have, someone has to be responsible for
Absolutely.
that patient's care. And in my limited view of the world, that is obviously a physician, a single physician, but nevertheless, somebody has to be accountable for that patient's care on an ongoing basis. Well, what do you make of the fact that the MedPAC report from this year, the current one, says that less than 2% of all duals are enrolled in some type of integrated care program? Are they just not counting accurately because they're missing all of you out there, or is it truly that we're only capturing indeed a very, very small percentage of the dual eligibles? Anyone feel free to answer.
I think MedPAC is counting when Medicaid and Medicare are putting funding together as an integrated approach, which the PACE model is an example where both Medicaid and Medicare are funding the care of that individual. Our program, which serves over 1 million, is still a fee-for-service system, so it's not, none of our individuals are counted in the MedPAC report. So the delivery system is integrated, the financing is not.
And what are the barriers to, or is there a problem with it being a fee-for-service system? Does that work well for you?
No, well, I think you have to align the incentives. There's still silos and there's cost shifting that occurs, so I think aligning the financial strategies and having, Medicare and Medicaid sharing in those responsibilities, taking care of, in this instance, the duals is really important. So I think that's why we wanted to be one of those 15 states to develop that integrated model, which aligns the integration with financing in addition to delivery.
But do you think more federal control is necessary? I mean, could you do your jobs better with a bigger and more powerful?
Well, I think you've heard ours is very local.
Yeah, I think so too.
Yeah.
Okay, my time's expired. I'll recognize Dr. Cassidy for 5 minutes.
Sir, the STAR Plus program. Now, I'm just trying to understand it. Ms. Bella said that 70% of the cost of dual eligibles in Medicaid is related to the custodial, not custodial, but the long-term care aspect of it. And most of the Medicaid acute medical expense, if you will, is the wraparound for that which Medicare does not cover. It seems like your savings are quite substantial if and I'm not challenging, I'm just trying to learn, that the provider or the MCO, the Medicare organization, managed care organization with which you are contracting, the only place they can lower cost is in the Medicaid component of the acute care. Is that correct?
That's not the only place they have to manage cost and achieve effectively better utilization. I think it's through a number of mechanisms on the acute and the long-term care services and support sides. Remember, we're talking in STAR Plus about the entire age, blind, and disabled population. It's not just a model for dual eligibles. So about 40–50% are dual.
I see.
So you have a acute care model of care that's integrated with the long-term care, and what the HMO will likely do, particularly for the Medicaid that's an age blind and disabled, is leverage those less expensive community-based services to keep them out of the more expensive acute care services, which is what we both want to do. We want to keep people out of nursing facilities and out of hospitals, and sometimes a personal attendant will do that for you, relatively inexpensive.
So let me just for a specific example, if you can use your Medicare dollar to get a personal attendant for a patient who is pre-nursing home, if you will, then that can save money on the Medicaid side, which would be a much greater expense, by using the Medicare dollar to pay for a service that would not be available under a Medicaid. Is that a kind of a
that's
good
correct.
example?
In fact, you might use a Medicaid cost to save Medicare money on the acute care side, and that's what we need to work through with CMS to talk about how we can leverage that to talk about some gain sharing opportunities.
Gotcha. Now, Mr. Bloom, although you said that you're not a health plan, you really do appear to be a staff model HMO. I mean, you're at risk.
Yeah.
And you're using your own people. If you will, you're the Kaiser Permanente of the frail and fragile. Is that a fair statement?
It's an absolute fair statement, absolutely. And I think we feel that burden every day and some of the requirements that we have to shoulder with respect.
Okay, then let me ask you, I mean, because I only have a couple of minutes, I don't mean to be rude. So when you speak of going beyond the duals into the Medicare only, again, effectively you're becoming a staff model HMO for Medicare patients.
Correct. I would argue, however, that what we're suggesting is not all Medicare patients, but those that we believe are high need, high risk, and need kind of a medical home.
Now, next, I've been fascinated with since Dr. Nilsson came from Baton Rouge to speak to her, and of course we know each other personally, and so and I've read about your program. But I've spoken to folks who criticize it as saying that really the cost savings are not there. In your testimony, you gave an anecdote which spoke of an individual, but that when you actually kind of run the numbers with a big spreadsheet, that PACE has not been shown to save money. Is that a fair or unfair criticism?
I think it's an unfair criticism. There has been a definitive government study, two of which actually, that looked at the Medicare cost and PACE and found that at worst we were budget neutral. On the Medicaid side, there has never been a definitive longitudinal study of PACE cost. Having said that, we continue to see states added to the list of PACE states. I think that what we've told states from day one is to the extent that you set your rates appropriately, all of which are significantly below nursing home costs, then you in the longitudinal measurement will save money.
Now, but again, maybe the criticism was that by keeping people out of the nursing home but still getting nursing home per diems, that you again, their Medicaid savings are not realized. Now, again, I'm channeling right now. I'm not.
Yeah. I mean, I think what you're suggesting is, yes, our PACE rate includes a component of costs that reflect the full risk that we are assuming for long-term nursing home placement. And there are, roughly on any given day, 7 to 8% of the people we serve are permanently placed in a nursing home at cost to us, not to the state. So again, the true benefits of the longitudinal...
So it's a cohort savings, if you will.
It's a cohort savings. So the state is literally, in many ways, similar to...
I'm about out of time. I'm sorry. Can you send those two articles that you have?
Yeah.
Now, Ms. Houston, the savings that you actually have your pediatric population in your CCN, and you have your duals in the CCN. Your savings you describe are global. What percentage of those are attributable to the dual eligibles? And that's my last question.
Well, I would say a greater percentage are due to the age-blind and disabled, which include the dual eligibles. So we have over 100,000 straight Medicaid age-blind disabled. So when we look at savings, we're looking primarily at the age-blind and disabled that are straight Medicaid, because we don't have all the data on the Medicare. So we're missing some of the hospital data and Part D and Part B data.
I've done a good job of analyzing your data. Could, again, you forward the more complete report on that?
Yeah, glad
Thank you. I yield back.
Gentleman's time has expired. The chair recognizes the gentlelady from the Virgin Islands. Dr. Christensen, 5 minutes for the purposes of questions.
Thank you, Mr. Chairman. I guess I have a pretty broad question that anyone could answer. I'd probably address it mainly to Mr. Millie, Mr. Bloom, and Ms. Lucen, but I know that minorities figure very disproportionately in Alzheimer's cases as well. But some of the sickest individuals in Medicare and Medicaid, of course, are racial and ethnic minorities. So can each of you tell me what percentage of your population are people of color, of those that you serve? Are the referrals proportional to the need? Is more outreach needed? And are you experiencing the same positive outcomes and cost savings in the racial and ethnic minority population compared to the others?
I don't have those numbers with me today. I do know that there is an equal benefit, but I just don't have those numbers with me today, but we'd be glad to get those for you.
Yeah, I can't cite specific statistics, but I'm fairly confident that the majority of people served by PACE are minorities. I anecdotally know of many programs where it's literally nearly 100% minority based on the population within which, or the neighborhood within which they exist and the likes. But I'd be happy to get you the specific figures. But yeah, it is a program that is focused on that segment of the population, absolutely.
We serve all the minority Medicaid population in the state. We have all the safety net providers participating in our program. And in the medical home models, when you actually look at some of the quality performance metrics, have been able to really show improvement in disparities, because if you're providing best care for diabetes, you're doing it across the board for all your patients. And so that's been a very rewarding quality metric that we've been tracking. I'll be glad to send you more information if you'd like.
Thanks. I know that they're there. We just weren't hearing about them, and I would expect that the models that you're talking about would be improving the care across the board. Mr. Bloom, have you had occasion to look at or been asked to look at the PACE model in any of the territories? And if you know, or do you foresee any barriers that would prevent you from setting up one of the PACE programs in one of the offshore areas?
We did have some initial and very preliminary discussions with Puerto Rico a number of years ago. They didn't progress into anything constructive after that, however. Having said that, we're always open, and I'm not aware of any barriers to expanding PACE into any of the territories, and actually would argue what little I know about the Medicaid program for the territories, that I think it would be very mutually beneficial. So I'd be happy to talk to you more about that.
To me too. Everybody's talked about, the need for your programs and the fact that your programs are really community-based. One of the amendments that I was involved in the Affordable Care Act had to do with grants for community health workers. And I was just curious as to whether you utilize them in your programs, and for Mr. Eggy, do you think that the community health worker would be a program that would be of assistance in the caregiving, even as the alternate caregiver in the Alzheimer's situation?
Yes, we have certainly found that's the case, that the services are provided in the community by social workers and by others can be tremendously important, especially at the early stages of Alzheimer's and other dementias, where people are still able to live quite successfully in the community. If they have that kind of support, we found that's extremely important to well-being for both the individual and if they're living with somebody else, for their caregivers as well.
Everybody uses community health workers?
We in North Carolina,
promotoras?
A lot promotores, and with the self-management of chronic disease, we engage community health advisors that actually live in the community that they're doing the chronic self-management program. So they've been very, very beneficial.
Thank you. We're always, at least I'm always concerned that the issue of quality of health care is often pitted against whether health care costs, as you're bundling and trying to bring these programs together. Do you see any problems in moving forward to ensure that the dual eligible health care quality and access and their health outcomes are not pitted against or held hostage to the health care cost containment issues?
Well, in STAR Plus, we believe the critical to that is the External Quality Review Organization, where we aren't dependent upon just the state's data, we aren't dependent upon the HMO data, but have a independent source to verify and look at the data that can measure, sure, the program is cost effective, but is providing high quality service or access to services where they should be. So we believe that is critical. And as we learn more about quality and its importance on the program, to change the program to respond to those concerns.
Anyone else? And that's my last
I'll
question.
just simply say that, in PACE, we are, as I mentioned, we operate at full financial risk for all Medicare, Medicaid, and medically necessary services, as with no carve-out, no copay, no deductible, no benefit limitations. We are immensely motivated and incentivized to provide good health outcomes. As the provider of care and the bearer of risk, at the end of the day, we're accountable. And it is truly in our best interest to get out in front individuals' care needs. And so that is what perfectly aligns the incentives within PACE. So.
Gentlelady's time has expired. Chair now recognizes the gentleman from New Jersey, Mr. Lance. 5 minutes for the purposes of questions, please.
Thank you, Mr. Chairman, and I yield my time to you, Mr. Chairman.
Well, that's very kind of you. Let me just ask you, Mr. Milwee, since we have a little additional time, you have talked in your testimony about the service coordinators, but some people would look at that and say, well, you're adding personnel, so you're going to be adding cost. How does that work? How do you justify that?
Well, some might speculate that would increase costs, but actually that service coordinator, remember that service coordinator is a clinical person who's working with that client. So that clinical service coordinator is actually a dollar saver in many ways, because they're identifying what that patient needs and how to get that for them, so that we can have those early interventions, so we don't have the hospitalizations or the nursing facility admits or the emergency department visits. So they literally pay for themselves time and time again by having that intervention and that, in a way, advocate to make sure that the people who need those services, whether they're Medicaid or Medicare, that they're getting those things.
So you have demonstrable savings that you can point to in your program in Texas?
Absolutely, absolutely.
And do you think that it works in Texas? Do you think it would transition or translate to work on a national scale?
Well, I think it could work in other states. I think the model is transferable. I don't think that people who are sick in Texas are any different that much, really, than people in Washington or California. But I think that they could. The model is completely transferable to other states.
Can you share data with the committee? Not necessarily right now, but is there data that you can share with us as to the actual dollar figures that have been saved?
We certainly can. We can provide the committee with that information.
And how do you get around HIPAA?
Well, we wouldn't provide you with client-specific data. We would provide you with de-identified aggregate information that would...
But more generally, how do the service coordinators themselves, how do they navigate the system under the constraints of HIPAA?
Well, they're working with the client as an agent of the client. So they can...
So they're fully integrated into it?
They're fully integrated into it. So they're not really burdened by HIPAA.
How do they monitor the day-to-day health of a patient?
Site
visits, or is it telephonic, or how do they do that?
It's not high-tech. It's high-touch. It's people talking to people, picking up the phone and talking to that person, finding out how they're doing. We do use electronic health records. A lot of the HMOs are moving to that, but it really comes down to a relationship and somebody caring about another person, picking up the phone and calling them and seeing what they need.
And, that's what is just so critical, somebody caring about someone else. And Mr. Egge's story that still haunts me, somebody caring about someone else, that wouldn't be happening.
Right.
I'm going to yield back the balance of my time and recognize the gentleman from Massachusetts for 5 minutes for the purpose of questions.
Thank you. Thank you, Chairman Burgess, very much. Mr. Egge, you did a good job in highlighting the important place for Alzheimer's patients in this discussion. More than 22% of seniors with Alzheimer's disease qualify for both Medicare and Medicaid coverage. Often these seniors rely on Medicaid to pay for expensive nursing home services. Since Alzheimer's patients can require constant attention, nursing home care for patients and Alzheimer's can ultimately wind up being 3 times as expensive as nursing home care for those without it. As a result of those costly nursing home stays, in 2004, the average Medicaid payment for a Medicare beneficiary over 65 with Alzheimer's was 9 times larger than the average Medicaid payment for other beneficiaries in the same group. As such, seniors with Alzheimer's represent an extremely vulnerable portion of the dually eligible population. I also have a particular interest in Alzheimer's since my mother passed away from it, which is why I created the Alzheimer's Caucus with Congressman Smith from New Jersey 13 years ago. I've seen it, firsthand, and I know the incredible commitment that our family had to make to keep my mother at home during that entire period of time. One ongoing problem is the disconnect between those in the medical office seeing patients and those in the home caring for them. In your testimony, Mr. Egge, you mentioned the bill that Dr. Burgess and I have introduced, the Hope for Alzheimer's Act, which would encourage doctors to diagnose Alzheimer's patients earlier after an Alzheimer's diagnosis is made. The bill that allows caregivers to be included in a conversation between doctors and patients to help plan for the disease and treatments. That conversation would give caregivers and doctors the reason to be working together, because it will be the caregiver who will help the patient remember their diabetes medication and avoid ending up in a hospital. In your testimony, you talked about John, who suffered from diabetes, but because of his Alzheimer's disease, found it difficult to follow his doctor's instructions. As a result, he ended up in the emergency room. And the doctors there were unaware of the Alzheimer's disease, which created a struggle to provide further care. Can you, Mr. Egge, explain how a formal and documented diagnosis of Alzheimer's will help to improve care amongst different providers and settings?
As we found from our experience that the documentation of Alzheimer's or other form of dementia is critical to care, and it's critical to coordinated care generally. So the reason it matters is because you cannot provide appropriate care if you don't know that dementia exists. We talked about how that pertains, of course, to how you handle instructions for compliance, for instance, whether that can be directed to the individual or should better be provided to a caregiver if available, or perhaps to a surrogate when not. So in that sense, it's fundamental. It's also fundamental when we think about documentation of the condition and medical record, because it follows then that person with a well-functioning system from setting to setting. We know that care transitions are one of the most risky moments for those with Alzheimer's and other dementias because of all the problems that can happen, especially in a hospital setting and others, as they transition in and out. So it's critical for this community that there is that documentation, diagnosis, then documentation.
Okay, so this is an amazing number, but just one disease, Alzheimer's, last year cost the federal government $130 billion out of Medicare and Medicaid. Just an astounding number. You know, it's about a quarter of the entire defense budget. And that's just one disease, Alzheimer's. How will the HOPE Act support caregivers and help provide them access to the resources they need to care for their loved ones, to keep them in home and as a result keep down the costs to the program?
That's a great question, and one element of the HOPE Act in particular is groundbreaking in that it provides for the first time for the healthcare provider to have consultations with the caregiver whether or not the individual with Alzheimer's or other dementia is present, which is extremely important because sometimes it's most appropriate for the conversation to happen in a number of different ways. So we applaud that innovation that's really built on the recognition of how important the caregiver is for these individuals.
Thank you, Mr. Egge. You know, by the time it's $130 billion now, by the time all the baby boomers have it, $15 billion, the bill for Alzheimer's will equal the defense budget. It'll be about $500 to $600 billion a year. So I think it's also calling upon us to increase the NIH research budget so that we can find a cure, because ultimately we can't balance the budget if we have a problem like this that is on the horizon. Thank you, Mr. Chairman, so much.
You know, time's expired, and actually that concludes today's hearing. I remind members they have 10 business days to submit questions for the record, and I ask that the witnesses all agree to respond promptly to these questions, and the committee is now adjourned.